The genitourinary system, the GU system, relating to the genital and urinary system. So it consists of two kidneys, two ureters, which are the tubes, one bladder, and one urethra. The kidneys are considered retroperitoneal. I also want to point out that going from anterior to posterior, you have the renal vein first, and then posterior to the renal vein, you have the renal artery, and then posterior to the renal artery, you have the renal pelvis. So this is considered the upper pole of the kidney. This is the lower pole of the kidney, and then you have this area here is the renal pelvis, and it is uh, most posterior, and it is continuous with the ureter. Here's a lateral view and showing that the upper pole is more posterior than the lower pole. And all of this is important when it comes to making a percutaneous stick of the kidney. Percutaneous antegrade pylography. So for that, the patient is prone and the stick comes from the posterior. So again, the anatomy kind of explains why that is. First of all, you're going to stick from the posterior because that's going to access the upper pole, and also you're going to stick the renal pelvis before you would stick the vasculature. So that's why a prone approach is used. So this is what an antegrade pyelogram looks like, and um, the renal pelvis is approximately 2 to 3 centimeters lateral of the transverse process of L2. Okay, so here's 5, 4, 3, 2. So here's L2, here's the transverse process, and so 2 to 3 centimeters lateral to that is the renal pelvis. So once the renal pelvis is accessed, urine is withdrawn, aspirated to make sure that you're in the uh, GU system, and then contrast is injected. And so that would be, and this is considered antegrade because it is with the normal flow. So here they have accessed the renal pelvis, they have injected contrast, and now contrast is going down the ureter. So a percutaneous nephrostomy tube is a similar procedure, and I like this picture because it kind of shows the calyces. So remember, you've got minor calyces, and then 2 or 3 minor calyces joined together to form major calyces. And so all of these, so these are the urine collecting structures, and then the 2 or 3 major calyces joined together to form the renal pelvis. So in this image, the catheter is seated in the renal pelvis, and so all of this funnel shaped as it tapers down into the ureter, that this area is the renal pelvis. So again, they have percutaneously accessed the kidney, and they are draining the urine via a percutaneous nephrostomy tube. And here's just yet another picture of a nephrostomy tube. Um, so again, percutaneous, there's the bag. This explains that there's a pigtail loop, so that it holds it in place. So what this tube does is drains the urine. Now, what's also important to know is why we would drain the urine, and that would be because there is an obstruction lower down. So there could be a kidney stone causing an obstruction. There could be cancer or malignant tumor obstructing the ureter. There's also other things, there's always all kinds of other pathologies that could cause that. Pregnancy even can press on the ureter and cause obstruction. And so why that is a problem is because if urine can't get out, if it can't trickle down like it's supposed to, then it becomes backed up in the kidney, and that causes damage to the kidney tissue. And so if enough kidney tissue is damaged, then the patient will go into renal failure. The kidney will fail to be able to filter blood like it's supposed to, because that's the kidney's job, is to filter dirty blood. And so if um, the obstruction causes urine to back up, that can cause damage to the tissue, and then the patient will go into kidney failure or renal failure. I also want to point out that this might be one procedure where they possibly would use CO2 or room air, carbon dioxide or room air, either one, as a negative contrast agent. And when the patient is prone, the air injected will rise, and so that way you can tell if it's a posterior or anterior calyce, and it aids with insertion of the needle into the proper place. Complications with this procedure, of course, there's always complications of hemorrhage, but specifically with this procedure, the complication of hemorrhage is due to inadvertent puncture of the renal artery. Also, sepsis could be caused due to if the urine is infected, that could inadvertently enter the bloodstream and cause sepsis. Okay, here is an ileal loop, and this is where the ureters are surgically connected to a detached loop of small bowel, and then the small bowel is then brought to the skin surface where a stoma is created. So of course this procedure is a surgical procedure, but once this procedure is done, it might be that we have to do a procedure on something like this. So it's not necessarily, so the actual procedure of creating an ileal loop is not something we do in an interventional lab, but we might encounter this, and so that we have to understand how this, what it is. It's the ureters are, so this would be for someone that has had bladder cancer perhaps, and their bladder has been removed. Okay, going back up to the percutaneous procedures, another one is a nephrolithotomy, which is just a fancy word for stone extraction. So again, once this catheter is in place, there's different things that can be done. Of course, this is demonstrating drainage. Then we talked about you could also inject contrast to do an antegrade pilogram, or once this catheter is in place, you can do a stone extraction. So so if there's a kidney stone, let's say here, then through this catheter they could take a different, a special type of catheter, a basket catheter, to grab the stone and extract it. So this procedure is sometimes done in conjunction with the ESWL, which is extracorporeal shockwave lithotripsy, or just simply lithotripsy. And also, too, remember these percutaneous procedures are in conjunction to or as an alternative to cystoscope procedures, where a cystoscopy is where they put a cystoscope through the ureter. And so there's lots of interventions that can be done that way. But sometimes if they fail, then you have to go the percutaneous route. So just keep in mind these aren't, the only interventional type procedures that are done. They're just the only ones that are done in our department. But there are cystoscope procedures as well. So for example, a stent placement. So again, these stents a lot of times are placed through a cystoscope. So you have a cystoscope placed up the ureter, or up the urethra rather, into the bladder, and then the stent is placed that way. Or it could be an antegrade stent placement, where again, for whatever reason, maybe the cystoscope procedure failed, and so now we have to do a percutaneous. So again, so now we are placing a needle here, creating a tract, and then that way placing a stent. Now these stents are a lot different than the types of stents that we use like in blood vessels. There's there's usually a pigtail loop in the bladder and a pigtail loop in the renal pelvis, and they again are to use to bypass the obstruction. In this particular, there's these yellow arrows are pointing to the little stone that's causing the obstruction, and so the stent is just kind of placed around it. Okay, the next procedure, a suprapubic cystostomy or a suprapubic catheter. So here, this diagram is demonstrating a disrupted urethra. So here's the bladder, and then this is the prostate gland, and then here it's just showing a disrupted urethra. And so for whatever reason, a lot of times it's because of the prostate gland hypertrophy of the prostate, or prostatic malignancy is what causes either stricture or disruption of the urethra, and so sometimes a suprapubic catheter has to be placed. So that procedure is done to drain the bladder when transurethral catheterization has failed. The next procedure, thermal ablation. So again, we talked about thermal ablation already a little bit, and that is usually a CT guided procedure, and where it's using radio frequency energy to deposit heat into a tumor. And damage to that tumor, to that tissue, is called coagulation necrosis. The temperature is in a range of 60 to 100 degrees. 100 degrees Celsius is boiling, and you want to, less than 60 does not reliably induce necrosis, and more than 100 degrees will cause boiling, which causes gas, which acts as an insulator, and so it impedes diffusion of the heat energy. And there's a really good YouTube video demonstrating a thermal ablation procedure, and I shared a link to that, so check that out.